Next speaker, Dr. Shruthi HR, Senior Resident, Department of Anaesthesiology, MMCRI, Mysore. Qualification MBBS, JSS Medical College, Mysore, MD, WIMS, Ballari. Publications, 2 international publications, and achievements Best Paper Award, State Conference 2014. Over to you, madam.
Dr. Shruthi is going to talk on the topic coronary circulation and anesthesia.
Good morning, one and all. My topic for today is coronary circulation and anesthesia. I do understand it's difficult to concentrate on anatomy and physiological lecture after a heavy banquet previous night. I try to make it a little interesting and colorful for you people. For the next 10 minutes, I'll be talking about the blood supply to that organ, which mainly supplies blood to the rest all the organs of the body. Coming to the blood supply of the heart, it's mainly supplied by right coronary artery and the left coronary artery. The right coronary artery after arising from aorta gives out the marginal branches through which it supplies the right atrium, the right ventricle, the SCA node, the AV node, and the bundle of Hess. And it also gives rise to the posterior descending artery, which runs in the posterior interventricular groove, supplying the posterior interventricular septum, the posterior and the inferior walls of the left ventricle. The left coronary artery, after arising from the aorta, immediately branches into left circumflex artery and the left anterior descending artery. The circumflex artery giving the marginal branches supplying the lateral wall of the left ventricle, and the left anterior descending artery which runs in the anterior interventricular groove supplying the septum and the anterior walls of the left ventricle. Depending upon from which artery the posterior descending artery arises, supplying the posterior interventricular, the dominance is decided. A person is called the right dominant if it arises from the right coronary artery. He is called to be the left dominant if it arises from the left coronary artery, or he is called co-dominant if it arises from both. Like most of us, like 85% of us are right dominant. Coming to the venous supply, most of the venous drainage, that 85% of it, is into the coronary sinus through the middle and the great cardiac vein, which drains into the right atrium. The anterior cardiac vein drains blood from the right ventricle into the right atrium, and around 15% of it is directly through the Thebesian veins. The heart at rest receives around 5% of the cardiac output, which is around 250 ml per minute, and the oxygen consumption is around 10%, which is around 25 ml per minute. So whenever the heart is exposed to exercise, the cardiac output, the oxygen requirement, everything increases. In order to meet these, the coronary blood flow also increases. Since we know that the myocardial oxygen extraction is around 70 to 80% at rest, any increase in the oxygen requirement has to be compensated by increase in the coronary blood flow. From physics, we know that the flow is directly proportional to the pressure difference across the vessel. So this pressure difference is mainly determined by the coronary perfusion pressure. It is that gradient that drives the forward coronary flow for the myocardial perfusion. It is mainly given by a difference of arterial or aortic diastolic blood pressure to left ventricular end diastolic pressure. From the table, we know that the systolic pressure in aorta is 120, while it's 121 in the left ventricle, whereas the diastolic pressure in aorta is 80 and 0 in the left ventricle. From the formula, we know that the pressure difference is around -1 in systole and 80 in diastole, which indicates that most of the blood flow to the left ventricle occurs during diastole. The heart has a capacity to maintain a steady myocardial perfusion across the range of perfusion pressures when the oxygen consumption is kept constant. From the graph, we know that over a range of perfusion pressure of 60 to 140 mm of mercury, the coronary blood flow is kept constant. But beyond this autoregulatory limit, the flow becomes pressure dependent. So whenever the pressure falls below 40 mm, as long as the pressure falls down, the coronary blood flow drastically decreases. The most commonly affected the muscle tissue is the endocardium, because it is increased exposure to the intramural pressures during the ventricle, and it's mainly supplied during the diastole. The coronary flow regulation mainly follows the Hagen-Poiseuille's law, which states that the flow is directly proportional to the force power of the radius, which indicates that the vessel diameter or the vascular tone has an enormous effect on the blood flow through the coronary flow. There are many factors which controls the vascular tone, the most important being the metabolic factor. The coronary circulation is extremely sensitive to the myocardial tissue oxygen tension, which indicates that whenever there is hypoxia, there is increase in carbon dioxide, potassium, hydrogen ions, lactate ions, which in turn cause release of adenosine, which activates the potassium ATP channels and causes vasodilation. Now, one more factor which influences is the endothelium, which modulates the contractile activity of the underlying smooth muscle by releasing factors such as nitric oxide, endothelial derived factor, bradykinin, prostacyclin, which causes vasodilation. The myocardium has an intrinsic property of contracting whenever there is a distension or increase in the intramural pressure of the vessel because of the increased blood flow. This is mainly activated through the stretch-induced receptors which are located in the smooth muscle fibers of the vessel. This effect is known as the Baylis effect, after William Baylis, who discovered this in 1902. The myocardium has a direct influence of the autonomic nervous system. It is under the sympathetic control through alpha and beta receptors, which mainly cause vasoconstriction and vasodilatation respectively. Though the parasympathetic effect is very minimal, it has a minimal vasodilatory effect through the muscarinic receptors. We know that the vessels, once they arise from the coronary arteries, runs in the epicardial surfaces, then gives it perpendicular transmural branches which end in the subendocardial plexus. So whenever during systole there is a contraction of the muscle fibers, these vessels automatically get constricted and there is no flow, and that prevents the perfusion. So from the blood flow during the cardiac cycle in this diagram, we can make sure that the maximum flow is during the early diastole, where the ventricular contraction is the least. There are many physical factors which either which modulate the coronary blood flow either by increasing the demand or by decreasing the supply. Coming to the effects of anesthesia on coronary blood flow, the most volatile agents are potent vasodilators. They act through activation of ATP sensitive potassium channels and they lower intracellular calcium, causing vasodilatation. Along with that, they also have a negative inotropic effect and also reduce the oxygen requirement and prevent reperfusion injury, hence beneficial in cases of myocardial ischemia. While halothane acts mainly on the larger coronary vessels, the isoflurane acts mainly on the arterioles. One disadvantage of the coronary vasodilatation caused by isoflurane is that it causes a detrimental redistribution of coronary blood flow away from the ischemic myocardium, what is termed as the coronary steal. Whenever we go for a regional blocks, either during a central neuraxial block or the thoracic epidural, there is a blockade of sympathetic system. So any sympathetic stimulation which causes increased oxygen demand is blocked in these conditions. Now we know that this is a condition of a normal heart, normal physio. What if something abnormal is there with the heart? Either if there is a working heart during exercise, or patient exposed to COVID, or when there is a failure of heart or occlusion of the coronary arteries. I would like to share an experience with you. A few weeks back, we gave a simple inguinal hernia case in a 35-year-old male patient. Intraoperative was normal, but in the immediate post-operative period, he suffered MI and had an arrest. Luckily, he was in the post-operative room and we attended to him, and after 1 hour of resuscitation, we could revive him and he was shifted to Jayadeva Hospital. There, a coronary angiogram showed complete right coronary artery block. Immediate PTCA was done and he was discharged after 1 week. Luckily, we were like there by his side. But the case was not so in cases of Dr. Puneet Rajkumar or many other youngsters whom we have lost because of MI at a very young age. This is to say that our myocardium has a ability to match the requirements whenever the demand is high, provided the coronary blood flow is good. For the coronary blood flow to be good, the coronary arteries need to be hale and healthy. There is one such indicator of the coronary heart to see if the heart is able to increase the coronary blood flow according to its demand. This is given by a coronary flow reserve. It's defined as the ratio of the maximal or the hyperemic flow down the coronary vessel to the resting flow. Normally it's around 3 to 5, which means that normally a person can increase the blood flow to 3 to 5 times in order to match the demands. Whereas it is decreased in cases of epicardial coronary artery disease or the microvascular dysfunction. One such condition is atherosclerotic or the coronary artery disease, where there is a chronic inflammatory deposition of fatty tissues in the muscle fibers, decreasing the lumen of the vessel. When such chronic stenosis occurs, the basal flow to the heart is maintained up to 80 to 85% of the stenosis, but the coronary flow reserve begins to reduce at 40 to 50%, and it almost reduces to less than 2 when at approximately around 75% of the stenosis. This indicates the myocardial ischemia. Since it's a chronic process, the myocardium has the time to adapt by developing the coronary collateral circulation so that the blood flow distal to the stenosis is maintained. But this is not the case in cases of acute thrombus or emboli, where there is a sudden occlusion of the blood supply to the muscle fibers, causing myocardial infarction. Another case is about a deadly pandemic we all faced is like COVID-19. A study has been conducted in US in 2022, which showed that the patient affected with post-COVID had impairment of flow-mediated epicardial vasodilatation and flow reserve. This is attributed to microvascular dysfunction secondary to endothelial damage. Such patients had 20% decrease in the ability to dilate the coronary artery disease whenever there is increased demand. Such patients would have a higher risk of adverse cardiac events. When such patients come to OR for us, it becomes sole responsibility of the anesthesiologist to see that such patients, we could save them through safety, through the tides of surgical stress and anesthesia. When we have to anesthetize such patients, we have to keep in mind the major goals of the anesthesia before choosing the choice of anesthesia. The major goals being to maintain the coronary blood flow, we have to avoid tachycardia, avoid hypertension, maintain preload, and decrease SVR. To conclude, I would say myocardium depends on a continuous supply of oxygen due to its limited anaerobic capacity. Whenever the flow is unable to meet the demands of the myocardial tissue, the myocardial ischemia occurs. So detailed understanding of coronary circulation, anatomy, physiology and pathophysiology helps us clinicians to tackle the issues related to stress induced by anesthesia or surgery and prevent perioperative morbidity and mortality. These are my references. Thank you.
Thank you, Dr. Shruthi.